Hello, my name's Jodie McCrossin, and I want to begin by thanking you for this opportunity to give a patient's perspective on patient-reported outcome measures in radiation therapy. 11 years ago, I was treated for stage 4 HPV-related oropharyngeal cancer in my tonsils, the back of my tongue and the side of my throat. I was 58 when I was diagnosed in 2013, and I will be 70 in October 2024. And my treatment was 33 sessions of radiation therapy and weekly chemotherapy. And I want to make it absolutely clear that I will be forever grateful to the large multidisciplinary team who treated me and saved my life. The radiation treatment for head and neck cancer patients affects our capacity to speak and to swallow, and it often leads to significant weight loss and both short and long-term side effects. So we really do need a big team for our treatment and recovery, and my thank you is very, very sincere if you've chosen to work in this field. The purpose of this presentation is to ask you to do 3 things if you haven't done them already. Firstly, I want you to set up a system for collecting patient-reported outcome measures as part of routine clinical care. Secondly, I want you to create a system for taking quick action to respond to physical or emotional issues of concern that are reported by the patient. When you're actually lying in a bunker on a LINAC with a life-threatening diagnosis, it's a very tough experience. So that when we need help, we need it quickly. There needs to be absolute clarity about who's responsible on the team to receive a report from a patient and then either respond or refer it to a team member who's able to respond. And thirdly, I'm asking you to build into your patient-reported outcome measures system the capacity to record the information you've collected from a large number of patients, so you can analyse the information you've collected and use the evidence of patient need to improve your care. PROMS are about improving systems for future groups of patients, as well as responding to individual patients during their treatment. So, just before I show you a great PROMS system from Australia, I'd like to say why I think head and neck cancer patients need to be given priority in PROMS systems. The suicide rate for head and neck cancer patients is a form of patient-reported outcome measure. Mark Twain, the US writer, he wrote, "Action speaks louder than words." And the action of suicide is a communication of distress. In the United States, for example, the suicide rate for head and neck cancer patients is almost 4 times the suicide rate for the general population. And head and neck cancer patients in the United States are 2 times more likely to die from suicide as patients with other types of cancer. This suicide rate is a measurable indicator of very high levels of emotional and physical distress. Yes, of course, we need more research to fully understand what's happening, but it's pretty clear that head and neck cancer patients need more help. And if we think the suicide rate of head and neck cancer patients is a patient-reported outcome measure requiring action, then during radiation treatment, we would give as much attention to emotional well-being as the attention to eating and swallowing. And I also suggest that we would develop late effects clinics for the years after treatment. But let me show you now a really good system in Australia at Princess Alexandra Hospital in Brisbane in Queensland. Dr. Bena is a speech pathologist and researcher who worked for 15 years in radiation oncology at this hospital, and she led the design, testing and implementation of a patient-reported outcome tool for radiation therapy. It's called My Health, My Way. Here's Dr. Brown explaining what My Health, My Way is all about.
My Health, My Way is an electronic web-based patient-reported outcome tool. So in cancer research over the last couple of decades, there's been a real push to hear the patient voice and hear the family voice during their cancer treatment, because it adds so much value to the care that we provide. So My Health My Way is a way for patients and their families to connect with their healthcare team. So patients enter their data of how they're experiencing treatment onto an app during treatment, and that directly connects with their healthcare team. So referrals are made to different members of the team based on the information they enter. So there's two different ways that people can enter their information. One is on a stand-up podium. So it looks kind of like an ATM machine in our waiting area. So patients and their families can come up to the screen. It's a touch screen. They can enter their data that way in the waiting room of our radiation oncology department. Or alternatively, people get sent out a personalised SMS message to their own device. So they can also complete their data in the comfort of their own home or when they're out and about. It doesn't have to be in the department.
So give me a sense of what sort of things I'm telling you as a patient, whether I'm doing it on the pedestal in the waiting room or on my phone at home.
So you're telling us information about how you're physically experiencing treatment, so any physical side effects you have related to pain or nausea or a whole range of different physical things that are specific to your cancer type. You're also telling us how you're managing at home practically, as well as how you're managing emotionally and how you're getting on with your family members and relationships with other people, as well as your experience of distress and things that might be contributing to that distress.
As you know, Bena, I have an interest in distress because I found the experience of radiation treatment with the mask tough. So if I was filling in the podium in your waiting room while I was waiting to go in, and I said that, you know, while I was in the mask I was sweating and going red and the heart was going fast, what would happen? What would happen after I reported that?
So there is a specific question that relates to mask anxiety on our tool. So people can tell us about their general anxiety, but separate to that, people can explain their experience of mask anxiety. And if your mask anxiety is at a level that is severe enough, then a clinical alert, as soon as you press enter on your data, a clinical alert gets sent directly to our occupational therapist and radiation therapists, and they're aware then from the moment that you enter that data that's what you're experiencing. So automatically a referral would be sent to those health professionals to support you during your treatment.
So have you done research on this? Do you have any data on what patients and family are telling you, or the impact, the evidence that this is worth doing?
Absolutely. So we've looked at all of the data that's come out through the My Health My Way tool, and it was previously called Screen It. And we have over 7,000 entry points of people who are reporting their data to us during treatment, and that's resulted in patients receiving the right care at the right time when it suits them and by the right professional. It's resulted in 25% less outpatient appointments needed for patients. So if patients are doing fine and they don't need to see their healthcare team at that time, then we cancel those unnecessary appointments. So it allows people to spend more time doing the things that they want to do rather than being at the hospital.
And Bena, just finally, where did this idea come from? I mean, as a patient, I'm thrilled by it. Where did this idea come from? Because it takes the hit and miss out of whether someone notices you're in trouble.
Absolutely. So I think we conceptualised the idea in 2013, and we had a feeling that we were probably over-servicing some aspects of cancer care. So we were seeing people too much and they didn't need to see us that often, but we were under-servicing other aspects like the psychosocial elements, so the emotional response to having treatment, the distress, the anxiety. So we wanted to find a way that we could understand exactly what was going on for patients and provide the care for those specific things.
Now, also working with Bena Brown was a radiation therapist called Andrew Puffett. And he was so moved by his observation of the level of anxiety that many patients experience when they see a bunker and a radiation therapy machine, or LINAC, for the first time, He created an educational system in the waiting area outside the bunkers at Princess Alexandra Hospital in Brisbane. So when you go into the waiting area, there's the My Health My Way screen that we just heard about, but there's also an education system.
So it's essentially an information kiosk that we have for radiation therapy patients. And I guess the idea was I wanted to familiarise the patient when they came, before they walked into that room, what they'd experience and what they'd see. And it uses an interactive touch screen. So it gives them a sense of control. So when we show them the linear accelerator or the treatment machine on the screen, they can manipulate all the components that we would as a radiation therapist. So by touching that screen and moving the components, they know, oh, this is what that does. It's not going to hurt me. It's going to take an image of me so the radiation therapist can line me up more accurately to give me that curative treatment.
And you, as part of being inducted as a patient at Princess Alexandra, do you show them this kiosk and explain what it's about?
Yeah, so when they walk in, our nurses or the radiation therapists will essentially stand them in front of the kiosk and they can swipe through the different slides on the actual program, and some of them will talk about the CT scanning process when they come for planning, and the others will focus on treatment. We also familiarise them with the staff. So we've got a really good allied healthcare program here at the Princess Alexandra Hospital, and it's one of the strengths of our radiation therapy unit because we can give patients that extra care they need. So we let them know those different support groups straight from the get-go so they know where to seek help.
Let me turn now to two senior Australian radiation oncologists who are doing great work on PROMS for patients in radiation therapy. Professor Jeff Delaney is Senior Staff Specialist in Radiation Oncology at Liverpool Hospital in southwest Sydney, and he conducts research with the Ingham Institute. And Professor Delaney was a member of the team who conducted the Prompt Care Study in New South Wales, Australia. The Prompt Care Study was an e-health intervention utilising patient-reported outcomes in routine clinical care. And the study involved 4 cancer centres and a range of cancers. Now, the study results included 26% fewer presentations by patients to emergency departments after adjusting for age, gender and stage of disease. Longer chemotherapy tolerability, improved quality of life, and improved survival for specific populations, such as people with advanced cancer and lung cancer. Now, this study is just one of several studies on patient-reported outcome measures conducted by Professor Jeff Delaney. So what does Jeff think are the keys to the successful implementation of PROMS in radiation therapy?
So I think firstly we need a workplace culture that embraces PROMS as an important and essential part of clinical care. We need clinical champions on the ground who are leaders within that health service to champion the importance and to maintain the rage. We need an electronic system that allows patients to fill out the questions in their own time and the data to flow in real time and to have an electronic system flagging those with high scores.
But flow in real time where?
Into the patient record. 4, a model of care with clear identification of the clinical staff responsible for actioning PROMS. And 5, a health system that recognises the benefits of PROMS where adequate resources are allocated to the collection and action on PROMS.
Associate Professor Puma Sundaresan is a radiation oncologist with Sydney West Radiation Oncology Network, and she's also chair of the charity Head and Neck Cancer Australia and president of TROG Cancer Research. I asked Puma why she's so passionate about PROMS, because I know she really is passionate.
I am, Julie. As Jeff said, patient-reported outcomes are direct reports from patients or their family members about their health status without any interpretation by other people, particularly clinicians. And patient-reported outcome measures, or PROMS, are the tools that we use to measure those outcomes, or patient-reported outcomes. You see, as clinicians, we've always sort of focused on survival, time to when disease progresses, or side effects as us clinicians would rate them. But traditionally, we haven't actually looked at the patient report as part of that process. Even though in the research setting in clinical trials for the past couple of decades, we've measured patient-reported outcomes when we're comparing one treatment against the other. We want to see if one's better than the other in terms of controlling disease, and we looked to see if patients' quality of life, was okay and wasn't affected, and it wasn't a trade-off in the process of getting that extra benefit. But we haven't used PROMS in routine clinical care. It's only in the last probably decade or so, Jeff, jump in, that interest in really trying to look at incorporating patient-reported outcome measures as part of routine clinical care has become of interest to clinicians. And I guess that's come from recognition that to deliver truly patient-centered care and quality care, knowing patients' function and their quality of life is pivotal. And us clinicians may not be the best people to, we're not the best people to assess that. So we have to hear it from the patients themselves.
Uma Sundaresan sees the integration of reports from patients into the patient medical record as critical to effective implementation.
Integration with the electronic medical record, I think, has been the biggest barrier to many of us. And I think it's because cancer electronic medical records have been locked systems, closed systems for obvious safety reasons. But, and we've had to work with the vendors very closely in order to create communication channels in and out of those locked systems. But integrating it is going to be the key. So I think that's a key thing. And my message to clinicians out there listening to this is start somewhere, start anywhere with whatever you've got. Because when you look at it, it is so big with so many barriers at the patient level, at the clinician level, at the health service level, that it all feels too hard. But start somewhere from wherever you're at, and you can build on it and improve on it.
Let's give the last word to a cancer survivor who hosts the Mouth Cancer Foundation support group in the United Kingdom. Karen's voluntary work for the foundation has led her to advocate for later fix clinics in her hospital.
I'm a survivor after 8 years of having tongue cancer surgery and radiotherapy. So I recognise the struggles that other patients go through with head and neck cancer. And the Mouth Cancer Foundation set up a weekly Zoom meeting for support for patients and family members in COVID. And it took off massively, was very popular. It's a safe space to talk. And I co-host that with Jocelyn Harding, who's a dental hygienist and president-elect of the Mouth Cancer Foundation. And the foundation decided it might be an idea to have another type of support in the Mouth Cancer Foundation support group, which is a private group on Facebook, which I man for them. And we have professionals there, but it's the main component of it is for patients and family members from all around the world to be able to connect and talk in another safe space. And I make it a mission to connect with each person that posts within the group, help signpost them and show them they're not alone, because it's a very lonely and isolating cancer and it's not talked about enough.
2 or 3 of the topics that come up again and again in your peer support work that you think are really tough for people who've had this cancer.
So initially you've got people going through diagnosis and surgery and treatment, which is tough going, so we support the patients through that. And then we've got the patients that are suffering afterwards with what is called late effects. Late effects can happen from 6 months, a year, and from there on. A lot of patients start noticing late effects from 5 years, some after 10, and they're finding it hard because there's not enough support out there. And that's another aspect that comes into it. And I don't want patients feeling alone with this. I know what it's like. I suffer. And it shouldn't just be a case of you've had your cancer, we've treated you for your cancer, on your way. It doesn't work like that, because we need quality of life, which is really, really important.
My time has run out, but if you'd like to see the full interview with Karen or with any of the clinicians featured in this video, you can see them on YouTube, or I'll put them on my website, www.juliemccrossin.com. I started this presentation with a quote from Mark Twain, "Action speaks louder than words." Let me finish with a quote from John in the New Testament that also captures the need for action, not just words. 1 John 3:18 says, "Let us not love with words or speech, but with actions and in truth." Thanks so much for listening.